Thank you. Welcome you all to the IAP PHO nursing session for the month of April 2026. So this month we are going to discuss an important topic, which is the chemotherapy administration, the safe practices and common errors. And we thought of having an interactive session with a case-based scenario after relevant theory. So this time, myself, Dr. Dharini, Senior Consultant Pediatric Hemato-Oncologist from Dr. Rela Institute and Medical Center, and one of our Assistant Nursing Managers, Ms. Archana, uh, who is leading the chemotherapy nursing unit at Rela Hospitals. We both will be doing the session today. Thank you everyone for joining. We'll just wait for a couple of minutes for some people to join and then start the session. Is there any feedback from the ECHO team?
No, ma'am. No, ma'am. At present, no, ma'am.
Okay, thank you. So I think we'll get going if that's okay. So we'll be doing together the session on chemotherapy administration, common errors, or case-based scenarios. So what are we going to discuss today? The basics of chemotherapy, safety of handling the drugs and administration of chemotherapy, prerequisites for each chemotherapy, what are the common errors that we come across and how do we prevent them, and some case scenarios. So to start with, what is chemotherapy? So broad definition may be different. So for us to understand it easily, it is a group of medication that acts predominantly on fastly dividing cells in the body. So the fastest dividing cell in the body is a malignant cell, a cancer cell, which divides very, very fast compared to the normal speed. So that is why it is cancerous. But there are some normal cells in the body which also divide faster every day. So the most important is the bone marrow, then our mucosa in the oral cavity, epithelium of the gut. All these will have faster regeneration. They regenerate once in 2 days. Our skin, hair, as we keep cutting, it keeps growing. So these are all the fast dividing cells in the body. So any group of medications that will affect these fast dividing cells is a chemotherapy. So what are the groups of chemotherapy that we know? The most common one is the alkylating agent. Alkylating agent, there are a lot of drugs: cyclophosphamide, ifosfamide, carboplatin, cisplatin. All these groups of drugs are under alkylating agents. There are some group of drugs called anti-metabolites, which particularly target some proteins in the cells. The 6-mercaptopurine, methotrexate, cytarabine, these are all anti-metabolites. And whenever the cell is dividing fastly, some drugs will go and bind to the DNA and damage it. So that group is mitotic spindle inhibitors, that is the Vinca alkaloids. The most commonly used chemotherapy, which is the vincristin, vinblastin, these drugs belong to this group. And etoposide belongs to the group of topoisomerase inhibitor. And we also use some drugs called daunorubicin and pegylated asparaginase, imatinib, dasatinib. These are drugs which are having action on some enzymes and proteins, and also the uh, targeted therapies. So chemotherapy can be anything. So like I told here, these are the various group of drugs that chemotherapy that is shown on the left side. Uh, these are the common names that you would have come across in everyday practice. and there are various metabolism mechanisms of action shown here. What we need to understand is that the cell has a DNA, RNA component. If the chemotherapy, like most of the chemotherapy agents will damage the DNA and RNA so that the further division of the cells becomes abnormal. So what is shown here is the normal cell and cancerous cells, the division between these two. So a normal cell will have control on its growth and control on its death. But when the control on the growth or control on the death of the cell is not there, that is cancerous cell. So that can be because of various mutations. We can there are two ways of treating the cancerous cell. One is non-specific. So whatever chemotherapy we generally use, they have non-specific effect on all the cancer cells and even the other normal cells. But there are some targeted therapy like rituximab, which targets particularly the CD20 cells, which is especially the B lymphocytes, imatinib, dasatinib. So these are called targeted therapy, which will affect particularly one protein. So there are various forms of chemotherapy that we come across. So we are moving into an era of a targeted therapy, immunotherapy these days. So cancer therapy, I mean chemotherapy is like an atom bomb. If you drop it anywhere, it will be a huge bomb and it will destroy everything in that area. Whereas if you refine it to attack only cancer cells, then that is called as targeted therapy. We have seen some examples. But when we give drugs which will stimulate our own immune system and make them fight against cancer cells, that is called as immunotherapy. So these are the advances that we are coming up. So chemotherapy is non-specific killing, and targeted therapy is specific target of some proteins inside the cancer cells. Immunotherapy is making the immune system fight against the cancer. So that is called as immunotherapy. So the newer drugs are called, the blinatumomab that we use, CAR T cell therapy that you might have heard. All these belong to the immunotherapy. The one common misunderstanding that everyone has is chemotherapy is very toxic and it will have a lot of side effects. Immunotherapy, because it is costly, it will not have any side effects. That is not correct. So the immunotherapy also will have its own set of side effects, but it is different from that of the chemotherapy. And of course, at this point of time, it is a huge cost for immunotherapy and targeted therapy compared to the conventional chemotherapy that we have. So these are some concepts and the theory behind the chemotherapy. What we do every day is most important. So the safety concern. So chemotherapy ordering has to be very meticulous so that we know that we are giving the appropriate drug at appropriate dose and dilution over appropriate duration and with an appropriate route to the patient, because we cannot have even 1% margin of error with these drugs. uh, in terms of even antibiotics or drug errors, you all know the implications of having any drug errors. With chemotherapy, the margin of error should be very, very, very low. So for that, we need to have some understanding and a proper system in place which is to be regularly followed. So the most important thing is the correct indication and the protocol has to be checked. So what we do is for all the for in pediatric oncology in general, we have a disease specific protocol that one particular institution follows. Like we know that for a B acute lymphoblastic leukemia, we have this protocol that we follow. So we have a protocol sheet and we go by the sheet. So we print the sheet and discuss with the parents and keep it in the file or with the parents and keep labeling the dates. So that week 1 the patient gets these drugs, week 2 the patient gets this drug. If any of the drug is skipped or if any of the drug is added, then we make a note in the protocol. So the correct indication and correct protocol is very, very important. So that is the foremost important of the doctor's team, the oncologist, and checking the protocol and ensuring that the patient has the protocol and they have understood it and they know where they are, marking the dates. This is again a duty of a pediatric oncologist, and we need to have a common understanding among the team members, all of us. So the ordering is done by the oncologist, and the concept, dose, everything is planned by an oncologist, but the administration and the monitoring, all this is done by the nursing team. So if we do not talk among each other, then whatever we have planned will not be appropriately reaching the patient. So the most important step is that we need to be constantly in communication, and to make the communication easier and more clearer, we need to have clear printed protocols that we do. And whenever the child comes for chemotherapy, any elective chemotherapy we never give when the child is sick. So when the child has a viral infection, had fever yesterday, so we are not going to push the child through chemotherapy. So so normally, so it's a duty. I mean, we can all discuss that. So sometimes we might have given a prior order for admission, and they might have reached the ward. So we have to ensure that the child is currently well and active, and there is no active infection going on. Yesterday night, the child had 101 fever. The parents did not tell anyone, and then they got admitted. We have to think, and we cannot proceed with the chemotherapy with an active infection. So all this are very, very basic steps. And the second important point is, most of the chemotherapy protocols, they will need a very basic absolute neutrophil count of at least 750 cells per cubic millimeter, and a platelet count of at least 75,000 to 1 lakh for prior to starting the chemotherapy. So there are some protocols which will give even when the counts are low. So that is different. Most of the times, for any Ewing sarcomas, or any solid tumor, Wilms tumor, neuroblastoma, or any child who's getting electively admitted, we expect the counts to be normal. Usually in leukemias, it is not expected to be normal always, but in all the other solid tumors, hepatoblastoma, all these things, we usually give chemo only when the child is well, no active infection, and counts are good. And we always check the liver and renal functions periodically and ensure that is normal. If any of these things are abnormal, then we have to either withhold the chemotherapy or modify the doses accordingly. So again, the point is that we need to check all these things before we connect a chemotherapy to the patient. So so the some before ordering, so I'll show you a model chart, how it has to be written. Though it is difficult to for anyone to write all the details every time, it is very, very important that we go through the steps and write everything in detail, so that the other person who is reading and giving the chemotherapy is very, very clear about it. So the two most important prerequisites, after checking the child is well, counts are good, when we start the chemotherapy, we have to ensure that two things have been charted there. So we always teach our residents, before they write the chemotherapy drug, actually they have to write the hydration first, then the antiemetics, then they go for the chemotherapy drug. Otherwise, if the antiemetics get missed, it is a very, very difficult situation for the patient. So having one episode of vomiting will be a nightmare for the patient for that episode, and even for the subsequent episodes. The fact that they may get vomiting, even if they think about it, they'll start getting a nausea, vomiting, and it is not a very pleasant experience. So we need to ensure that we try to avoid the nausea, vomiting at any cost. So most important times, we start the hydration first, 100 to 125 ml per meter square per hour. And so for some chemotherapy like cisplatin, we have to add magnesium, calcium, potassium, because we will either give mannitol or diuresis along with the drug. So at that time, they may lose magnesium, calcium. So the protocol again is very important. So the hydration has to be started first, and antiemetic prophylaxis is very important. So the chart shown here shows the emetogenicity of each chemotherapy. So I will not go in detail here, but there are some drugs which we know that they are very, very high emetogenicity. So if we give, definitely they'll have vomiting. So the most important drug that we need to remember is cisplatin and cyclophosphamide, doxorubicin, ifosfamide at a higher doses. So cisplatin name should come here. So anyone getting cisplatin, they should at least get two antiemetics before we start the chemotherapy. Most of the drugs are in the moderate emetogenicity group, and very low emetogenicity group is the lower one. So most of the tablets, targeted therapy, all these are the minimal emetogenicity. Moderate emetogenicity will include all donorubicin, doxorubicin, cyclophosphamide, cytarabine, ifosfamide, methotrexate, or carboplatin, all these things. So the one point, if you want to remember, cisplatin is very highly emetogenic, and most of the drugs will need antiemetics. And one drug which will not need antiemetic is vincristin, vinblastin. So they are least emetogenic. So for vincristin, vinblastin, we do not administer antiemetic prophylaxis regularly. So this is how we check the body surface area. So the errors can happen anywhere. So from checking the weight, documenting the weight, checking the height, documenting the height, calculation of the BSA, everything at each and every step things can go wrong. So we always double check the weight and height. And as a clinician, as a pediatric oncologist, or even an experienced nurse, you will also know that a child, if she is 3-year-old child, they cannot, if the weight is written as 23 kg, unless the child is obviously obese, you will definitely think it cannot be 23 kg. So we have to use our common sense here and there. So double checking the weight. And sometimes if whether a number that we write as 1 may look like 2, so the common sense application is very, very important. So weight, height, calculation of body surface area using this Mostellus formula that we regularly do. There may be already available charts for the calculation of BSA based only on the weight. It is also applicable, I mean, okay to use them, but in extreme body situations like extreme malnutrition or extreme obesity, they may be wrong. So it is always better to calculate this body surface area with the current weight and height and then apply it. So write it legibly, verify with the parents. So last time எவ்வளோ இருந்தாங்க, what was the weight of the patient, what was the height of the patient, whether they have changed, they have increased, or we have noted it wrong. So better to look for all these things. The most important thing is we should not be overdosing. I mean, underdosing is still okay. Overdosing should never happen. So once we have had a situation of a 4-year-old child where the weight was written as 29 kg and the calculation was correct, but the weight was written wrong. So invariably everything goes wrong. So I hope you all understand the importance of writing the each and every value clearly and calculating it correct. So this was the model chart that I was telling you, that how we write the chemotherapy. So we write the date, time, and the body surface area. So we try to write the drug name of the drug, and we write the dose, we write the date, we write the dilution. So along with the appropriate rescue measures. So what date to what date, what time to what time. If this is written clearly, then it is always easier for anyone to follow the instructions easily. So the chemotherapy ordering, yes, it will take time, but it has to be done with appropriate time. Our director or my mentor, Dr. Julia Scott, he used to say that while he was getting trained, they'll be given a protected time, that 1 day or half a day, they will be sitting and doing only the chemotherapy ordering for the next week. So that is how the importance, while he was in training in Australia. So that is the importance of the time and mental peace that we have to give for a person who is ordering the chemotherapy. So there are some checklists. So whenever we know that the cyclophosphamide or ifosfamide is being given, we need to ensure that they are hydrated for at least 2 to 3 hours before starting the drug, because these are two drugs which can cause significant hemorrhagic cystitis. Once it starts, it is very, very difficult to control, and the pain is definitely a very, very worse situation for a patient. So hydration, pre-hydration is very important for cyclophosphamide and ifosfamide, and we need to ensure that the mesna is available, because mesna is usually given at 0 hours 4 hours or 0 hours 4 hours 8 hours. So there are some, based on the dose of cyclophosphamide and ifosfamide, we give mesna periodically. That should not be missed. So we cannot order only cyclo, and mesna is not available in pharmacy. There is no point in having the cyclophosphamide. So better to have both together and ensure that both are available. And whenever we start a high dose methotrexate for any patient, folinic acid is the rescue drug. So that has to be available in case of any toxicity or even as a routine protocol. So we have to ensure that folinic acid is available in the pharmacy before we start the methotrexate. Otherwise, we should not be even starting the chemotherapy at all. There are some medications which will need a proper pre-medication because it can cause allergic reactions. The most notorious ones are gemcitabine, rituximab, and even bleomycin. So these are three drugs which can cause significant allergic reactions or infusion reactions. So they need pre-medication. We usually give Avil hydrocot or even sometimes dexamethasone for a pre-medication. And the most important point is we need to ensure whether the drugs are compatible with
Excuse me, ma'am.
NS or 5% dextrose. So we have to check the compatibility of the chemotherapy. So for example, carboplatin, oxaliplatin, these are drugs which we usually mix only in 5% dextrose. And there are some drugs which are
Excuse me,
mixed.
ma'am.
Yes, please.
Yeah, yes, please repeat the appropriate dilution NS 5% dextrose completely. How much drugs?
So, usually the drug will have an insert, and the drug insert will mention what are the compatible IV fluid solutions. So, carboplatin, oxaliplatin, usually we mix in 5% dextrose, and all
Carboplatin and
oxaliplatin. Oxaliplatin is another group of platinum drug, which are usually mixed in 5% dextrose, and most of the other drugs are mixed in NS. So this is very important that we see the drug insert or the drug protocol books and then write the chemotherapy. So it is important again from the oncologist point of view, but to have a manual from the nursing side and then checking that is also very important. And whenever a child is charted vincristine and the child is also getting voriconazole, posaconazole, you should ensure that the doctors have adjusted the doses. So this is called drug interaction. So what happens is voriconazole will increase the drug levels of vincristine, vinblastine. So the toxicity of the drug will become very high. So we would have given the correct dose for the body surface area, but because there is a drug interaction, there is voriconazole is also given along, the the vincristine dose will be pushed up, the levels will be pushed up. So these are some practical points. Again, it is important for an oncologist, but for an experienced nurse in pediatric oncology, this is very, very important. So any just there are not much interactions in between the chemotherapy drugs that we commonly see. Two things that you need to remember very strictly, which are very commonly used, is voriconazole and vincristine. So whenever we give vincristine, that particular day we will not give voriconazole, or we have to reduce the dose of vincristine. So either one thing has to be done. And whenever children get high dose methotrexate, we should not be giving the routine Septran prophylaxis. So these two drug interactions you should remember, so that we are not giving the children without so that we increase the toxicity. So avoid the abbreviations. We try to avoid abbreviations in all the prescriptions. MG is definitely a standard thing we can use. And microgram, it is better to write microgram in full rather than using the symbol or writing MCG, because we tend to make mistakes. When we read, we can make mistakes. Units, rather than writing just U, better to write units fully. We just write one time for that one patient, so better to do it fully. And this is one model protocol that we have posted here. So whenever there are 2 or 3 drugs which come in periodic interval, like you see here, the GCSF is there for daily 7 days. Fludarabine is not there on first day, and then there are 5 days. And that bortezomib drug you see there are on particular days. So we have put the dates and we have marked those dates so that even when we get confused and write it on a different date, you can check with the protocol. So this protocol, giving it to the patient and ticking whenever we are connecting the drugs, is will actually help us to ensure that we have given and ensure what is given. Sometimes if you ask the mother 2 doses given or 3 doses given, they will not know. So it is better you give the protocol, write the date after you administer, so that we know that this date this drug has been given, which can be seen by everyone. We take informed consent for all the drugs and after appropriate counseling of the patients. And so prior to the chemotherapy, there are certain particular organ specific monitoring which has to be done for some particular chemotherapy. For example, donorubicin and doxorubicin are cardiotoxic drugs, so they can have cardiotoxicity. So we have to ensure that a 2D echo is done before we start the drug. And even those children who are getting repeated dose of doxorubicin, we keep repeating the echo after every 2 to 4 cycles, so that the cardiac function is maintained normal. So this is very important. Cisplatin can cause hearing disturbances, ototoxicity. So we have to check the audiology hearing assessment every periodically. And carboplatin can cause nephrotoxicity. We have to check the glomerular filtration rate with specific scans. And before starting the methotrexate, we have to ensure the urine pH is more than 7. So we give the soda, we give hydration with soda bicarb and potassium chloride, particularly to make the pH more than 7. We have to ensure that, then only start the methotrexate. And the most important point is we need to ensure the whether the line is good, and then we are starting. So I told you already, the immunotherapy, the rituximab, all these can have the side effects can be significant. So we have to watch for infusion reactions. And the standard neutropenic care, appropriate diet precautions, they are very important. So again, one example of adrenaline to be kept loaded and ready for any L. asparaginase or pegylated asparaginase. We usually write this order. We do not give pegylated asparaginase, and if there is any allergy, then prepare adrenaline or load adrenaline at that point of time. That is not correct. 99.9% of the times, whatever adrenaline we load, we are going to only discard. But we have to keep it ready, load the adrenaline, then only give pegylated asparaginase, because suddenly the child can have anaphylaxis, and your adrenaline which is loaded will only be the life-saving medication. So these are certain precautions that we should know before we start the children on chemotherapy. So again, the double verification. So in our unit, we follow this policy very strictly. So we write the chemotherapy drug in the chemo chart, and whatever protocol we are using, we will post it. So we have a WhatsApp group. So this is one good use of the WhatsApp group that we use in our unit, as guided by our mentor. So we post the drug chart that is written for the patient and the protocol for the patient, so that even if they are not around, they can check whether the drug orders are written correctly. So the weight, height, body surface area, everything is written correctly. Once that is approved over properly, then only we go for administration. Verification at the doctor's level, between the doctors and nurses and the clinic, will definitely reduce the error that can happen. And like I told you already, the unit writing it fully is very better to avoid abbreviations. And it's always better to write 0.5. Put the 0, otherwise we don't know whether it is point is incidental or it is because of some error. So 0.5, it is very important. And it is better, don't write 1.0. That does not give any meaning. So especially for chemotherapy like vincristine, we have to be very, very careful. So with this, I request Dr. Archana's sister to take over how we do the further preparation and handling.
Yes, ma'am. I am Archana, chemo senior staff nurse. So chemo preparation. How do we are preparation means we have to BSc cabinet, biosafety cabinet, several precautions. Clinical pharmacists there, privileged clinical pharmacists and nursing stations, safety for the nurses and the medical staffs. Then central preparation labeling. This is the preparations. Then handling of the medications. First one is verification, very very important. Verification, preparation, and administration. Then appropriate personal safety measures we have to follow. Then appropriate disposable. In case of disposable medicines, we have to segregate C symbol. Then administration, we have to always check for the 10 rights, like patients, right medication, right dose, right time, right to route, and right
Sister, your
documentation.
voice is a bit
Okay,
feeble.
sir, is ma'am? Hello.
Sister?
Bedside, yes,
Yeah.
ma'am.
Yeah. Your voice was a bit feeble. Now we can hear you, please.
Okay. Bedside with appropriate labeling, double checking the identity, ensure before giving medicine, ensure the good backflow and forward flow. Then ensure hydrations, especially in cisplatin, cyclophosphamide, and hypophosphamide. Measures how to we are safe, ensure measures to safety. We have syringes like syringe with vials. How many ml? Especially when interesting, we have to measure 0 points. Then documentation and communications. We have whenever given interesting wind blasting, make sure this is a correct. That's point 0.1 or 0.2. Then communications. Chemotherapy administrations verification is very very important. Vincristine and vinblastin entirely different dosing. Then daunorubicin and doxorubicin different indications. This is to show whenever completing intrathecal procedure, we never allow to inside the vincristine. After completing medicine procedure only, we have to allow vincristine along with the intrathecal medications. Then sound like medications. Antibiotic is colistin. Colistin is a GCSF. Then lookalike drug. Lookalike drug. This is a this is a methotrexate and 6-MP are totally different medications. This is a look like medications. Chemotherapy dosing verifications. Omnicotal fort is omnicotal fort and omnicotal. This is a same different drugs. Okay, ma'am.
Yeah, thank you, sister. So, like she said, the points, so we have to ensure at every step. So, we would have written prednisolone 10 mg. So, they might be giving the omnicortal fort the same ml, which might be double or triple dosing. So we have to be ensure every time when the various preparations are available, I mean the various dosing preparations are available, we have to ensure every time. So the first time if we check it is correct, the second time they buy a new bottle, better to check again. Third time they buy a new bottle, better to check again. So first time they may be right, second time they will change. So it's better to educate the mothers or the caregivers who give the drug about it to check what has to be done. Even if they are completely illiterate, if you just show them that 5 mg bar 5 ml versus 15 mg bar for 5 ml, they will definitely understand. Methotrexate is another common drug that comes in various preparation. The 2.5, 5, 10, 20, many preparations are available. So basically we have to ensure. So we will be writing 5 mg, but they might be giving 7.5 mg. So this has to be ensured. So we'll go for some case scenarios. So this is a 1-year-old boy with Langerhans histiocytosis. He's due to get vinblastin. His weight is 8.5 kg. And body surface area we have calculated is 0.43. And the vinblastin, as per protocol, it is 6 mg per meter square per dose. So if you calculate 6 mg per meter square, it is 3.6 mg. So can we proceed with this? Anyone wants to give any comment on this? If anyone wants to unmute and answer, you can. Or you can post your answers on the chat box also. So is everyone okay with this order? It looks correct. Body surface area looks correct. Dosing looks correct. So can we proceed?
Maximum vincristine dose is up to 2 mg.
Correct, sister. So very good. So she has already answered my second question. So this is vinblastine. So vinblastine is 6 mg per meter square. So somebody has said no, we cannot. So why is very important? Yeah. So the point that sister made is vincristine dose, the cap maximum is 2 mg. Vinblastine is not 2 mg. It is up. It can go up to 6 mg. So
Ma'am,
very
correct
good.
dose.
Somebody has said dose is 2.58 mg. Can you please tell how it is? Mohit Kumar, right? So what we need to understand is actually, so whenever it comes to extremes of weight, most of the protocols they will say for all the babies weighing less than 6 months or babies weighing less than 10 kg or 12 kg, the weight is the dose is usually mg per kg. And in older children, it is usually as per the meter square. So if you apply this mg per meter square here, you will definitely give a very high dose. So this is the protocol of that LCH where you see clearly that the weight of the dose of vinblastine is 0.2 mg per kg per dose. So if you calculate as per this, the dose is 1.7 mg. So it is hugely different. So it is almost double. So we cannot be using it and it is very, very toxic. So why is this difference happening is because the body surface area. So why we don't use only weight per kg? So most of the antibiotics and other drugs in pediatrics, we can go with the mg per kg for dosing. Why in only in chemotherapy we use the weight, height, and calculate the body surface area is because the body surface, I mean the body mass index is calculated by your fat content, water content, and also the other solid tissues like your muscles and bones. So the entire most of the drugs chemotherapy, what it will do is it will go and bind to the fat and it will slowly get released. So to adjust if someone is very obese, then we cannot go with the direct weight per kg. For a 5-year-old child who is as per the correct weight, who is 15 kg and who is obese, both we cannot give the mg per kg dose. So if you calculate the body surface area according to their height, the height will adjust your errors, and the body surface area will actually give us the correct dose that is needed for the body, not to be stored in the fat. I hope you understand this concept. So that is why in children, where usually they have more fat content in general compared to the other body mass, the other lean body mass like your muscles and bones. So we need to go with the per kg body weight and not the square meter. So this is very important. So whenever you see an infant or any child who is less than 10 kg, always question whether they have written the correct dose as per the protocol for the less than 10 kg or less than 6 months dosing has been followed. So most of the protocols will clearly say if the baby weight is if the baby age is less than 6 months, you have to reduce the dose by 50%. You have to reduce the dose by 25%. So that has to be ensured before we give. So this has been already answered by sister earlier. So adolescent boy TALL obese, I mean the body surface area is 1.99. The vincristine usual dose is 1.5 mg per meter square. So it comes as 2.9. But again, yes, it should not be given. There is something, this is called a ceiling dose or capping dose. So there are some drugs for which you can only give maximum of 2 mg vincristine. Like that, phenytoin, this is the maximum. Whatever may be the weight, this is the maximum adult dose. So we cannot exceed those doses or ceiling doses. So we should be aware of those ceiling doses in pediatric oncology. So only drug that where there is a ceiling dose is vincristine, vinblastine. For vincristine, it is 2 mg. Vinblastine, it is 6 mg. So unusually high doses, again, please recheck that. So a 2-year-old girl with a BALL, and she had a very difficult venous access, and somehow we have managed to give the vincristin, but while you're giving the vincristin, there is a swelling. So what to do here? So this is a common scenario we have already discussed. When extravasation of chemotherapy has to be considered as an emergency, uh, do not panic and remove the IV line immediately. That is the most important learning. We should aspirate as much as drug as possible and then remove the IV line. Elevate the limb. Keep a warm compress for Vinca alkaloids or cold compress for the doxorubicin, daunorubicin, and specific antidote has to be given immediately so that we are able to manage, reduce the tissue damage. So warm compress for Vinca alkaloids and cold compress. So you can remember V and W are close in alphabets. So warm vincristin, warm compress. And doxorubicin, C and D are uh, close to each other. So doxorubicin extravasation will give cold compress. So this is again important. So do not remove the IV line immediately. Aspirate and then remove. So 5-year-old boy, high risk TALL, we are giving something called as high dose methotrexate. You would have all seen over 24 hours, 3000 mg, 4000 mg over 24 hours. So this child has been admitted on Monday, and you are doing a drug recall, reconciliation when you are writing. Your mother is saying that I've given Septran Saturday, Sunday on weekend. So can we proceed with this prescription of methotrexate here? Yes. So many of you have said no. Yes, because
Interaction with the methotrexate.
very good. So methotrexate and Septran have interaction. Methotrexate and Septran both can affect the bone marrow, and each will increase the side effect or the marrow toxicity of both. So what will happen? The child can have a very, very profound cytopenia. So ideally, what we do is before 48 hours of starting the methotrexate, we should not be giving them the Septran prophylaxis. So we tell them if the child is due for admission on Monday or Tuesday, we have to tell them not to give that weekend prophylaxis with Septran. Missing Septran 1 week is okay, but we should not be giving the methotrexate and Septran together. So like I said, hyperhydration at least for 6 to 12 hours, and making sure the urine pH is more than 7, and ensuring that the folinic acid is ready before starting the methotrexate. These are all very, very important. Methotrexate is one drug where we actually do a therapeutic drug level monitoring, meaning we do the drug levels at 48 hours, 72 hours to check the drug has reduced well in the body before we discharge the patient. So this is important to ensure the toxicity is not there. Urine pH is not a very big thing. If you think, that you have to bill for a urine routine and it takes time, so these are the pH strips that you might have all seen definitely. So the pH strips are available. It can be kept in the ward. For one patient you can use one strip and see whether it is exceeding 7 mark, and then you can start the methotrexate. So there are some timing and interaction with food that we need to know. So you will be explaining the discharge medications to the patient. So you should be aware of certain things. So 6-mercaptopurine or 6-MP is one common drug that all the children with ALL will be taking. So we have to know that we should not be given along with milk products. So what we say in general, most of the children will be school going. So when they come back from school around 3 or 4, we tell them to give the drug immediately. They would have had lunch by around 2 o'clock. If they give the drug between 4 to 5, we can keep another 1 hour fasting for solid and milk products, and then give the food around 6 o'clock. So they can take plain water and juices during that time, but not the milk products, and preferably solid food. So this is very important because 6-MP is the most important drug for maintenance therapy in ALL. And if this is not working because the food interaction is reducing its efficacy, then the chances of the disease control going less is very high, and the chances of relapse is higher. So we have to ensure that we explain this to the parents. So what is the medication to be started 1 day prior to initiating a drug called irinotecan? So we need to ensure. So this is irinotecan is one drug where we have to give cephalosporin prophylaxis. So cefixime is one drug which we use to start 1 day before the drug, starting irinotecan, to avoid severe diarrhea related to the drug. So this is again very important, and to stop the diarrhea because of irinotecan, we have to use either atropine or loperamide. Again, ensure when you're starting a drug called irinotecan, we have to ensure cefixime is being given to the patient and the loperamide is already available. So Archana sister, can you tell us how you would go with the PICC line, port line handling and how to be careful?
Yes, ma'am. Pickling and port handling. Always use sterile aseptic precautions. In case of line displacement, even can even happen with CAD. With be careful. Appropriate flush monthly. Once we have to tell them to patients. Flush heparin flush is very very important. Then, in case of errors, medication errors, uh, if no pharmacist, some lack of knowledge is there, then no single guidelines, then no cross checking, no accountability, timelines not maintained, no drug list display, daily order entry, no monitoring, then no electric setup for calculations, different medications in different consultations, then no monitoring, lack of positive attitude, then short stuff. This leads to medication errors. In case of arrest happen means we have to raise incident reporting first, then including adverse reaction also is there, raise incident reporting, then admitting the error may help in administering an appropriate interventions at the right time. It may help devise measures to reduce the recurrence of such errors. In case of take yes, ma'am.
Yeah. Thank you, sister. So, like she said, the chemotherapy, we have discussed a lot of points, what to give and what not to give. I know it is a very huge topic. My understanding the mechanism of each will not be done in one class, but I'm sure you would have known that hydration, the role of antiemetics, role of timing, role of writing, checking, all this important. So when everything goes wrong, anything goes wrong, there can be a medication error. Like we said, it can be just mislabeling or mischecking or some which is not appropriate for the patient. So better to have a group where we can discuss it together. At least the doctors, the important team members from the doctors nursing group and the clinical pharmacist, and always cross verify with the parents. And whenever we give at least 10 or 20 chemotherapy per day in one unit, it is, we cannot, if we say that we don't do any error, yes, we may be very right, but if we, it means that probably we are missing identifying some error. So we cannot be always right, and in most of the very good systematic units also the errors may happen. So what differentiate a good unit and not good unit from is that when the error happens, if someone is going to blame each other and try to just escape from the situation, yes, that is not right. Yes, we admit first, like she said, we report the incident, we ensure what has happened from each personnel, we do not judge anyone, we do not question anyone, we just ask them what has happened, why they have thought so, whether they were working a long time, whether they were given extra shift, whether they did not have the understanding, whether the doctor has written it wrong. Every step has to be done, and it is always a good attitude to just come and sit together, see this has happened, and the better to avoid it next time, and we should be having a system better than this. So that is hopefully the best situation for us to go forward. So baby on board is a safety measure that people use on cars. So that is the same thing that we have to use on with the children with pediatric oncology nursing also. So a very important thing is appropriate indication, appropriate ordering, verification, legible writing, and safety of your own self. So any of the staff nurse who is expected to be pregnant or pregnant, better to be away from the chemotherapy mixing areas and handling, because these are the chemotoxic agents you do not want to get exposed to in the first trimester. So take care of yourself also when you are actually caring for the others. So it's not only safeguarding others, so the safety of handling, the proper gloves, proper disposal, everything is very, very important. So with this, we always consider the nurses as angels who stand between us and the patients. And you are the strength, you are the bridge that I mean, that combines us. So if the bridge is very strong, then definitely the outcomes are expected to be very, very good. So with this, I would stop the session. There are some comments on the chat box. So yeah, so it's again, somebody has commented about giving temozolomide before irinotecan. Yes, very good. When we are giving multiple chemotherapy, like 3-4 chemotherapy on same day, so the protocol itself will mention this has to be given first, this has to be given next. So that has to be followed. It's very good point. Somebody has asked, can you explain the importance of folinic acid rescue and action of it? So methotrexate, like I told you, is an anti-metabolite. It is an anti-folate drug. So what happens is it binds, it is an anti-folate drug. So you all know that folic acid is very important for all the cells to grow and proliferate. So the chemotherapy will actually kill the, I mean, the methotrexate will act against folate and induce apoptosis. So the normal cells also will need folic acid. So we need to rescue the normal cells from the toxicity. So that is why we give the folinic acid. Folinic acid will rescue only the normal cells and not the cancer cells, because of some particular mechanism which is present in the normal cell and not in the cancer cell. So folinic acid is given for all high dose methotrexate to rescue the normal cells. Otherwise, it can lead to hepatotoxicity, renal injury, and significant mucositis. So Dr. Wahid has posted, any chemotherapy medications not needing laminar flow for mixing, or do all medications need? I think the laminar flow is mainly for the sterile handling and the safety for the people who are doing. So even in our unit, I mean, even a simple Vincristin, which is used on everyday basis, is also done in a laminar hood. Archana sister, am I right?
Yes, ma'am. Including impression also will mix laminar wood flow, ma'am.
Yeah, so it is mainly for the safety in my understanding. So we do, even if it's 0.1 ml of Vincristin, we do with that. So that is my understanding about it. Savitri sister has asked, in case of extravasation of paclitaxel and oxaliplatin. So the warm compress and cold compress concept comes for mainly the vesicants. Vesicant drugs are the Vincristin, Vinblastin, doxorubicin, and daunorubicin. So because they are going to cause a huge tissue necrosis after extravasation, they are called vesicant drugs. So the other drugs that you have mentioned, paclitaxel, they are not vesicant drugs. They are irritant drugs. For irritant drugs, you need not be worried about extravasation much, but still you can do the limb elevation and aspiration and all that, and ensure there is no specific antidote or specific compress for all these things. For anything, warm compress is particular for Vincristin and Blastin. For all the other, cold compress can be considered. Yeah, atropine before irinotecan, yes. So some units might be giving it regularly before irinotecan, but we in pediatric oncology, in our unit, we usually do whenever there is a diarrhea. So the incidence of diarrhea that we have seen with children with on irinotecan is very less. So maybe hardly around 5 to 10%. So we do not pre-medicate all the children with that. So yes, but we have to be ready with atropine and loperamide. So some other things like, I mean, better to see, we all work for the patients, and the safety is very important. Our safety is important, and the proper coordination is important. Chemotherapy is never an emergency drug. It has to be done during the routine working hours. but sometimes we may, because if we are not organized properly because of the workload, we may get postponed and things may get pushed to the end of the day, where we might be in a hurry, and when we do multiple things can go wrong. So it's always better to plan for the next day. In our unit, or they always give us the list of chemotherapy for the next day. They keep the drugs prepared so that the patient doesn't come and wait for the drug from the pharmacy. They get it immediately once the patient gets admitted. So these are some systems that you can have amongst yourself to avoid the stress during the chemotherapy. So the chemotherapy, if not come for 1 hour after admission, the parents start shouting, then that adds some stress on us, and we do make mistakes when we are stressed. So we should be very sure about certain things that has to be done on a regular basis. We try to avoid connecting the chemotherapy drugs very late in the evening when there is less manpower in terms of doctors and nurses. Even when there is some toxicity, we cannot directly address and monitor. So better to give all the elective chemotherapy in the daytime when we are actually around. Any drug which needs monitoring for anaphylaxis and infusion reactions, you better connect it during the uh, daytime when we are all around. So these are some practical points that we should be noting down. Yeah, so correct. So some drugs we need to give at BD, like cytarabine, high dose cytarabine, we have to give 12th hourly. So such times what we do is we educate the parents. When we give for the first time, we ensure that they come in the daytime. The first dose is given in the daytime, so that even if the second time it has happened, we can justify to the parents that it is inevitable, and we have monitored the first time. Yeah. Yeah, chemo like carboplatin in case of gynec patients with ascites and desaturation. I'm not sure about the medical oncology related indication of carboplatin. Yes, it might be. Yes, there are some chemotherapy definitely we need to consider as emergency. I'm not against it. But when we do that, it's better to do with a proper place to monitor. Whenever it's an emergency situation, most likely the patient is going to be in an ICU. So there you need not worry about monitoring. So otherwise in chemo ward, when you connect and when we leave, there is no one for monitoring, then that becomes an issue. An emergency patient, emergency situation, you're connecting chemo in the middle of the night in an ICU, it is definitely acceptable thing. So these are some practical points that we should be considering to make it safe for the patient and also us, to save us from most of the stress and the legal errors. More than the legal accusations, I'm sure all of us, we have our own conscience that will kill us. So if we make any mistakes, or even if we don't make a mistake and something goes wrong also, people always feel bad about it. So try to reduce the chances of such errors so that we can do the stressful work with a better peace. So I think with this, we're already almost time now. So with this, we will close the session. Anyone else wants to make any final comments? We can. So if there are no questions, then thank you so much for everyone. It has been a very interactive session, like I've seen for most of the times. Thank you everyone for this wonderful listening and interaction. We hope to take it forward with further enthusiasm. I hand over the session. Thank you, Archana sister, for accepting to do it at a very short notice. I'm very sorry that I didn't give you much time. And thank you for taking it and doing it, and all the help that you have been doing meticulously with our patients. So even I'm sure I am capable in ordering chemo, because if I make a mistake, she will definitely find out and point it very subtly so that we never have gone wrong so far. So with that, we'll close the session. I hand over back to Echo. Thank you.
Thank you, ma'am.
Thank you.
Thank you, ma'am.